All right, what's up, everyone? Happy Wednesday. Another free weekly Zoom, as usual. I'm back. I'm here. We were with each other last week. That one I did put up on YouTube. So I hope you all were able to go back and watch it. We even left the trivia up on there as well, too, so if you wanted to go through and do it. What's up, everyone? What's up? So you guys can hear me okay? I'm trying out a new mic on here, so I just want to make sure everyone's got me nice, loud, and clear. Cool, perfect, awesome. So today we're going to talk about pneumonia. Pneumonia is something that's very prevalent, especially during this time of the year. And there are different types of pneumonia. And it's like CAP, VAP, HAP, AP. And I'll explain what all those mean here shortly when we get into it, community acquired, hospital acquired, and so on and so forth. But before we get started, we do have somebody that made it to the other side that wants to share their story. So first and foremost, let's talk to Nurse Yadira. Where are you at?
Hi, Dr. C. Can you
Hi,
hear
Nurse
me?
Yadira. How are you?
I'm good. And you?
Doing well, doing well. So we made it to the other side.
Yes, yes,
Nice, nice.
finally.
So how many questions were you?
96.
96 and out. Let's go. We didn't make it to
Yeah, yeah,
50. That means you were doing really, really, really well.
yeah.
And what of NCLEX High Yield did you use, Nurse Yadira?
Um, I did the live course in March, and
Okay.
I use your podcasts, and your little book, the clip. This book,
Okay.
yeah,
Quick
I
tip
use that
books.
one.
Yep. Those are going to be in stock soon
Yeah,
here shortly.
yeah, yeah.
And what is your
I
advice for people on the other side?
believe in God, believe and that I can do it. So is our test, right?
Oh,
You
you're
can do
cutting
it. If you
out.
study hard, you can do it.
Yeah, absolutely, absolutely. I think our connection is really bad, Nurse Adira. So um, I'm not hearing everything. So what we're gonna do is we're gonna cut this interview a little bit short because you're cutting in and out. So, but nonetheless, Nurse Adira, thank you so much for joining us, and congrats for making it on the other side. 96 and out, 96 and
Thank
out,
you.
and
And first try.
your first try. There we go, first try. Or you came right back in.
Yeah,
Perfect.
and I'm international nurse. English is not my first language. Spanish is my first language. I'm from Dominican Republic, and I
Okay.
took my test in Orlando.
There you go.
Very
So
hard.
first and one and done, one and done. So
Yes,
nonetheless, we definitely we are proud of you. You're in the March live course. The live course paid off, one and done.
yes,
We're ready to start making that paycheck now.
yes.
Let's go. All
Yeah,
right, Nurse
yeah,
Yadira, thank
yeah.
you so much
Thank
for
you,
sharing
thank
your
you,
journey.
thank you,
Thank you for sharing your journey with us.
thank
Take
you.
care. Thank
Bye.
you. Bye-bye. All right, let's get started on a few announcements and we'll get started on our lecture. All right. Again, as usual, financial assistance letter. Use it, use it, use it. Please write it out, send it out to everyone. We've created the template for you. Go ahead and utilize that. Print it out, send it out to religious community organizations, friends and family, work, whatever it is. Tutoring. Remember, all our tutors were in your position. They all took the course. They are now tutors for NCLEX High Yield. They report to me. They are trained by me. So you're literally getting one-on-one with basically a person that is just like me. All our free resources. If you're not subscribed to our YouTube channel, subscribe to it. If you're not subscribed to our podcast, Instagram, TikTok, subscribe to them. I put different things out on different places. Our self-paced course, we are doing a flash sale, and our January live course is now available as well too, with dates up. We're going to be starting it on the 5th through the 21st. Again, remember, you can check in with me until you pass. The live course has 6 to 8 hours of extra stuff that's not put anywhere. It's not on your on demand. It's not available anywhere. It's just application practice questions. It's your tutor going, or whoever the instructor is going to be doing extra material in those specific areas as well too. Our on demand holiday flash special. They dropped it to $199. If you don't have the on demand, this is only going on until Sunday. That's it. They're only doing it till Sunday. So if you don't have the on demand, and it's $199 right now, get it while it's so cheap for the holidays, because come New Year, it's going to go right back up to almost $300. So you're saving a lot of money on that, Another holiday flash sale with Nurse Brittany, our one and only Nurse Brittany, my second in command, basically, after me. Nurse Brittany is on special, 5 hours for $250. You can use them anytime. So you're saving almost 20% on this. If you want to book them, or if you want to get them now and book them later, do it. Because Nurse Brittany is the second most, the person that teaches the second most in the course. We are now just started an WhatsApp community. I know a lot of our students use WhatsApp. I know WhatsApp is becoming a great means of communication. We started a community. If you want to be able to talk with us, we're going to be posting some cool stuff on there, just like we do on social media, but some different stuff. If you make it into that community, then we're going to do some special stuff for you as well there. So make sure that you're in there so you can get in first dibs on everything. Again, one-on-one tutoring if you need. All our tutors are phenomenal. Rapid review as well too, if you just want something as a breakdown of the high yield stuff as well too. WhatsApp is open to anybody. It's open to everyone. They'll put the link in there as well too. Okay, your CPR report. If you have a CPR report and you want me to talk to you about it, you want Nurse Brittany to talk to you about it, there's some things on the CPR report that people don't understand. They get a CPR report and they're like, what does this mean? This doesn't tell me anything. I really don't understand it. So again, if you want to have us break down your CPR report for you and kind of guide you, submit your CPR report using this code. And we'll go over it with you so you know exactly what just happened when it comes to your CPR report, because a lot of times we don't know what it means. And lastly, if you do want to speak to us, myself, Nurse Brittany, our staff, we will call you. I'm making calls basically from tomorrow till Sunday straight. So keep your phone next to you if you've signed up. And I will be making phone calls. Nurse Brittany will be making phone calls as well too. So if you need anything, please do let us know. On to our lecture. What we're going to be talking about today is pneumonias. Why is pneumonia so important? Because one, it is that time of the year. People are starting to develop pneumonia. And we're starting to see them a lot in the hospital, in the ER, in the ICUs. We're starting to see in the community, we're starting to see a lot of people developing pneumonia. What do the boards want to know about pneumonia? What does respiratory section and med-surg want you to know about pneumonias? Well, the first thing we need to do is we need to define the different types of pneumonia. So when I said CAP, HAP, VAP, AP, what does that mean? Well, the first one is community-acquired pneumonia, CAP, community-acquired pneumonia, which means I'm developing it outside of the hospital setting. I'm out in the community. I'm out and about. Maybe I went to a cruise. Maybe I went to the mall. Maybe I was in school, whatever it is. Ultimately, I got it from the community. I got it from outside the hospital. So we're looking at outside of any type of healthcare environment, hospital, clinic, so on and so forth. The next one is hospital-acquired pneumonia, meaning I've developed this in the hospital. Why are these so important to differentiate? Because the bugs that cause them are different. VAP is ventilator-acquired pneumonia, meaning my ventilator, patient on a vent, mechanical ventilation, has now developed pneumonia, typically occurring 48 to 72 hours post-intubation. The next one is aspiration pneumonia. Completely different. In this situation, we actually inhale something from our gastric content. And now, because that foreign body, that foreign substance is in my respiratory tract, I develop pneumonia because of that. And this can happen anywhere. And we'll talk about the different risk factors for aspiration pneumonia as well. The last one, which we're actually starting to see a lot of, it's kind of in the news, it's all over articles, is atypical, or what they call walking pneumonia. Walking pneumonia. And the reason why this is starting to pop up is because what causes it is very different than all the other ones. And that pathogen is something that's starting to spread big time, because the way we spread it is through respiratory droplets. And this can be in the community and or outpatient clinics as well too. Now, tell me, with these 5 different types of pneumonia, do you think this is a great board question? 100%. 100%. Causes, treatment, signs and symptoms. Yeah. You think I can build a case study out of this? You better believe it. Do you think we did build a case study out of this? We sure did. Do you think I could make a bow tie question out of this? You better believe it. You think we created a bow tie question for this? We sure did. Because what we're starting to notice is that majority of people are starting to see more next gen than traditional. But the traditional is still there, so don't forget about it. But we're going to do a bow tie and a case study, and then some traditional questions as well too, if I get around to it. Excuse me. What do we need to know about these? Well, again, look at how these are laid out. Tables are laid out like what? This is 100% laid out on purpose like what? A matrix or a grid, right? This looks like a matrix or a grid, 100%. The common pathogens. So what is the bug? What is the bacteria? What is the infectious process that is causing community acquired? So what's out in the community that we're going to get from one person to the next person? Which leads me to talk about precautions. If you don't know your precautions, you must know them inside out. Droplet precautions, standard precautions, we must know these. So which are the ones that cause pneumonia? Community acquired. Well, think of the most common ones that we deal with. Strep pneumoniae, Haemophilus influenza, and mycoplasma. In that order. Well, do we have vaccines for 2 of these? And if so, which 2 of the 3 do we have vaccines for? We've got HIB and pneumovax, pneumonia. 1 and 2, strep pneumonia and Haemophilus influenza, HIB and pneumovax. With patients that are at risk or that we're concerned about, elderly patients, or children, are we giving them HIB? Yeah. Are we giving them pneumovax when they get older? Yeah. Which leads me into vaccines. You think vaccines are important? You think we should know about influenza vaccine? Our live vaccines versus our non-live vaccines, or killed vaccines? You think we should know about pneumovax and HIB? Absolutely. Influenza? Absolutely. Nasal, intranasal versus IM. Sub-Q if we're dealing with somebody that's got a bleeding disorder. Do you see pregnancy, maternity? You see where we're dealing with this? Geriatrics, pneumovax. Everyone above 6 months for influenza. So much that we're dealing with, not just different types of pneumonia. You got to think about the big picture when you're studying for boards and or studying for school. Hospital-acquired pneumonia. Now the bugs start to change because hospital-acquired and ventilator is going to be what? In a hospital setting. So now the bug changes. The bug changes to Pseudomonas. Pseudomonas is going to be your predominant one that you're going to get in the hospital, in a hospital setting. So whether you're on a vent or you're in the hospital, we're concerned about Pseudomonas. Why is this important to know? Do you think my treatment changes based on the bug? Absolutely, it does. 100% it does, right? Different bacteria demand different types of antibiotics. The second one that we develop in the hospital is MRSA or Staph aureus, because this is methicillin resistant, right? Which means, is a penicillin going to work? Broad spectrum like penicillin? Is that going to work on this? No. So we've got to think of other options. We've got to think of other options. The next one in hospital acquired is Klebsiella. Klebsiella. Not super high yield, but just for the sake of completion. And same thing with Acinetobacter with ventilator associated. Not super high yield, but for the sake of completion. The next one is risk factors. So we talked about smoking. How many people watched or listened to my last podcast / YouTube video where I talked about COPD and just kind of clarified it a little bit? I see Nurse Tony, I see Nurse Zareen. I see you all doing raising your hand. Good. I like that, because do you see how COPD is an umbrella term? A lot of people think that COPD is a diagnosis of its own because we write COPD, but in fact, there are things underneath it. I need to know what type of COPD you have, what type of obstructive pulmonary disease you have. And smoking is going to lead to which one under COPD? Is it chronic bronchitis it's going to lead to, or is it going to lead to emphysema? It's going to lead to emphysema, right? So smoking, which means I've got an obstructive lung disease, which means, can I clear out any infection if it comes in? No. So we're very, very concerned about any of these developing into what? Sepsis or airway. Ask Graf. Ask Graf. Airway above all else. All of these can lead to airway. Are we there yet? No. All of these can lead to sepsis. Are we there yet? No. Elderly, hence why we do a pneumovax. Asthma, again, an obstructive lung disease, medical condition, not chronic, but it's still an obstruction. Any type of recent viral infection can be compounded with a bacterial infection. Remember that. If we're already compromised, bacteria is going to take advantage of that. With hospital-acquired pneumonia, well, look at your ICUs. How many have worked in the ICU or in the ER? Spend a good amount of my time in both. And what were we always worried about? We're always worried. What do we always get on a patient in the ICU? Typically, we order what? Almost regularly, we have a standing order for what? A portable chest x-ray, right? What are we looking for with the chest x-ray? We're looking for infiltrates. We're looking for pneumonia. We're looking for atelectasis, right? We're looking for different things that can be acquired in the hospital. So ICUs, long hospitalization, or if you're immunosuppressed and you're in the hospital, you're more susceptible as well. With ventilator-associated pneumonia, we're worried about, obviously, them being on a vent. So intubation is a risk factor. Prolonged ventilation. When you talk to your respiratory techs in the ICU, those that decide to go into the ICU, the one thing they're always going to try to do is what? We're going to see if they can tolerate being taken off the vent. Always seeing if we can wean them off. your respiratory tech is going to be pushy. They're going to be like, hey, can we get this patient off? Can we get this patient off? Because we don't want them intubated for unnecessary reasons. Because of this, it will lead to airway. It will lead to sepsis if we don't do something about this. Keeping them in a supine position. Again, do you think you need to know your positions? Yes. Supine, prone, fowlers, semi-fowlers, left lateral. You think you need to know these? 100%. 100%. And reintubation. If we're constantly intubating them, of course, they're at risk for ventilator-associated pneumonia. Signs and symptoms. Well, we're worried about cough in both of these because they're not intubated. So these signs and symptoms are not going to overlap as much. But in community acquired, we're worried about fevers, chills. Again, same thing here. But we can develop that pleuritic chest pain, which means when I breathe in and out, my lungs are going to cause pain. And with hospital acquired, we're worried about dyspnea and purulent sputum. With ventilator-associated pneumonia, we're worried about increased secretions, hypoxia. And then again, same thing, we're getting imaging done regularly to make sure we have no infiltrates. Diagnosis, chest x-ray, chest x-ray, chest x-ray, right? Because we can see pneumonia. We can see that there is infiltrates in the lungs, that the alveoli are starting to get packed up on a chest x-ray. Things like blood cultures are going to give us an indication of what type of bug it is. Because is it limited just to the breathing in and out, or is it going to start to get into our bloodstream, or did it come from there? Yes, yes, and yes. With a patient on a vent, we can actually do a bronchoscopy, which is not necessarily what we want to end up doing, but again, same thing, chest x-ray, sputum, but we can actually take their aspiration and culture that. We can take their secretions and culture that. So the treatment for community acquired is macrolides. And I'm going to write a little mnemonic up here. So macrolides, know the mnemonic ACE for the different types of macrolides. Azithromycin, clarithromycin, and erythromycin. ACE for macrolides. ACE for macrolides. So now we're doing a little bit of pharm, okay? A little bit of pharm. So I've done antibiotics before, but I haven't done it specifically on macrolides to this extent. So know these. Azithromycin, clarithromycin, and erythromycin. These are your macrolides. Which leads me to my second mnemonic, macro. These are my side effects. Macro for macrolides is my side effects. First one is motility. What is motility issues? What do you think is happening? What do I talk about in pharm in general? Good. In pharm in general, I talk about most or a good majority of drugs. If they have a side effect, how is it going to present? Usually it's going to be GI issues, right? Motility issues, nausea, vomiting, diarrhea. The A is arrhythmias. So we're concerned about our QT interval. Now let's talk about this. In the course today, what did I talk about? I talked about our QRST complex, right? Our QRS complex QT. In this situation, our QT interval can get prolonged. If it gets prolonged, well, my QRST is what part of the heart? It is the ventricle. Good. which means if I prolong it, can that snap into a dysrhythmia? And what's the dysrhythmia I'm worried about with QT prolongation? VFib. VFib. What do we do about VFib? Synchronized or unsynchronized? Unsynchronized, because it is in fact the same thing as defibrillation. You see, we just went from respiratory, pneumonia, to pharm, to EKGs, to GI. Do you see how medicine, you can't just sectionalize it, right? Very important. The C is CYP450. Who knows what this means? What is CYP450? Cytochrome P450. It is an enzyme in the liver that breaks down medications. So what is this telling me? It is metabolized by the liver. So you think I'm worried about their LFTs? I am. The R is the use for it, which is respiratory infection. So it's not just side effects, but just to make the entire mnemonic complete, it is used for respiratory infections. And then the last one is ototoxicity. And what do I talk about with ototoxicity? Vision and hearing. What are we always worried about? Irreversible damage. Irreversible damage. So cool little mnemonics. Write these down, write these down, write these down. Cool. What do y'all think so far? Pretty cool, right? I don't know. I kind of geeked out about this lecture. So, so yeah. So a little bit of pharm, a little bit of cardio, a little bit of everything. We're doing it all. We're doing it all. The other ones we can do is we can do doxycycline. Inpatient, we can do ceftriaxone. Remember, cephalosporins have that 10% cross-reactivity with penicillins. And then again, we talked about ceftriaxone and then adding on that azithromycin. So if you think about it, when you talk about patients that you see, or if you've been a patient that had some sort of chronic bronchitis and or pneumonia, what do they typically prescribe you? Anybody know what is that thing called? Azithromycin that we give out. 6 pills, 5 days, a Z-Pack. Good. Just to kind of put things into perspective. That's what azithromycin is, right? So a Z-Pack. Good. Now, with hospital acquired, right? We're dealing with Pseudomonas, Staph aureus. We're looking at gram positive and gram negative, right? Pseudomonas being gram negative, Staph aureus being gram positive, which means I've got to give them what type of an antibiotic? I've got to give them broad spectrum IV antibiotics. Broad spectrum IV antibiotics. So penicillins work just fine, cephalosporins, fluoroquinolones. We've got so many different types of medications that are broad spectrum that cover both gram positive and gram negative. So again, just broad spectrum antibiotics. There's a lot more as well too that are broad spectrum. With MRSA, what do we know about MRSA? Vanco, or linezolid as well too. With management, now people ask me all the time, Dr. Z, what about basic care and comfort, right? I've talked about basic care and comfort being such a big topic on the boards, because if you don't do well on basic care and comfort, chances are we're not going to pass. So basic care and comfort. So what is the mnemonic for basic care and comfort? I'm going to go back up here a little bit so I have some room to write. Another mnemonic for basic care and comfort is safer. So supportive care. What is supportive care? Basic care and comfort. Give me some things. How about fluids, position, oxygen, comfort in general, right? So supportive care. A is antibiotics. Antibiotics. F is fever control. So analgesics. NSAIDs, fever reducers. E is educate. And what are we going to educate them on? Needs. You think nutrition plays a part in developing pneumonia? Yeah. If you don't eat healthy, you become obese. You think obese people have more chance of developing? Yes. They're not using their lungs. They're not exercising, which leads me to tell them to exercise. You think people that smoke or that drink can develop pneumonia? Yeah, their immune system is not necessarily going to be optimal. Don't smoke. Clearly. Sleep. If we sleep, do you think our immune system is going to be optimal? No. If we don't sleep properly, no, it's not. So educate them on their needs. And the last one is rest. So again, management, basic care and comfort for patients with pneumonia. The next one is aspiration pneumonia. This is different because we're actually aspirating. That foreign body is what's causing me to develop this pneumonia. So that inhalation of gastric contents, how do I develop that? Well, how about people with impaired swallowing? People with strokes, neurological disorders? How about alcohol intoxication? We talked about this heavily last week, did we not? We talked about alcohol intoxication, but we didn't even talk about aspiration pneumonia. I could have taken that whole lecture into a respiratory section. But here we are. GERD, that reflux disease, seizures. Again, all of these become or can become airway, 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 and sepsis, sepsis, sepsis. So again, same thing, anaerobes is the big one because these anaerobic infections are ones that are not exposed to oxygen. It's that gastric content that is being inhaled. And now we are developing aspiration pneumonia. So signs and symptoms. Well, if I get something down the wrong pipe or I've got pneumonia, am I not going to want to cough that out? Of course. So cough. Am I going to have trouble breathing? Yes. Is my sputum, because it's an anaerobic infection, foul smelling? Think about anaerobic. They're not exposed to air, which means anybody ever had to deal with a cyst or an abscess that was infected? Anybody ever had to cut one open? Yeah. How does it smell? Not pleasant. Not pleasant at all. So these anaerobic infections become very pungent in smell, very foul smelling. In this situation, it's in the lungs. So our sputum is going to be what's foul smelling. And why does it typically go to the right lower lobe? Anybody know? Basic anatomy in the lungs. Right lower lobe, because on the left side is the heart. So now we've got our access to the right side of the lung a lot easier, a lot easier. Cool. Diagnosis, again, chest x-ray, clinical history, treatment. With the anaerobic, we're going to do clindamycin or amoxicillin with clavulanic acid or clavulinate. That's augmentin, amoxicillin with clavulanic acid. If I spelled it wrong, I apologize. And the last one is atypical pneumonia or walking pneumonia. And the atypical pathogen, the most common one is mycoplasma. Mycoplasma pneumonia, chlamydophila, and Legionella. And again, water droplets, respiratory droplets. Legionella actually can be spread through water in general. Water fountains, things like that. Drinking fountains, water fountains. It can spread through those as well too. But mycoplasma is the one that we're going to typically see, not super high yield as to identifying it, but just know atypical pneumonia, the way that we're dealing with this, the age range for atypical pneumonia you're going to see is going to be younger. It's going to be 5 to 30 for walking pneumonia. Crowded living spaces. So what type of a situation would I have where it would be indicative that this patient is coming in with walking pneumonia? Patient, here's an example. I'm making this off the top of my head right now. I'm going to give you a case study. No, I'm going to give you a bow tie, okay? I'm making up a bow tie off the top of my head right now, so you can see how I make questions, okay? I'm making a bow tie, and I'm going to make my 4 diagnoses, and you're going to tell me which one it is, okay? Here's a bow tie. Tell me what the diagnosis is. So your option choices are hospital-acquired, community-acquired, aspiration, or atypical pneumonia, okay? Those are your options. HAP, CAP, atypical, and aspiration. And I'm going to give you a scenario in a bow tie, and I'm going to give you a patient that is 21 years old. Patient complains of coughing, shortness of breath, O2 sats 96%. Patient has now developed a fever of 101.8 and is visiting the college campus nurse. What's my diagnosis here? A 21-year-old. I would take CAP, but what makes me go to atypical? The age and the college campus. They're living in a dorm. You see the difference? So could it be community acquired? Yes. But why did I throw atypical in there? Which one is a better diagnosis? The better diagnosis is atypical. Community acquired could be anybody in any situation. In this situation, I'm giving you 2 clues: age and the fact that they're seeing college campus nurse, meaning they live on campus in the dorms. Fair? So great way to differentiate atypical from everywhere else. This is going to be gradual onset, low-grade fever, dry cough, headache, myalgia, rashes, some other things that are not necessarily super high yield. The hemolytic anemia is not very common, but can happen. Again, chest x-ray. So what am I going to do? Patient comes in with pneumonia, any type of pneumonia, community-acquired pneumonia or walking pneumonia. What are we going to do? We're going to order a chest x-ray. So what type of a question is that? It's a straightforward freebie question. What is the most appropriate action? Go back to that bow tie. What is the most appropriate action? Actions are freebie questions. What are you going to do? How are you going to treat this? And that's going to be what? You think chest x-ray is going to be in that column of bow ties? You better believe it will be. You better believe it will be. And if you want a little bit more specificity, we do a PCR, your polymerase chain reaction, not something that's super high yield, or serology, again, not super high yield, again, for the sake of completion. But this is the one I want you to know. And we just talked about our #1 line of treatment, macrolides, ACE. Azithromycin, clarithromycin, erythromycin. I know your side effects. All right. How are we feeling so far? Good, good, good. All right. Let's do some practice questions. So the first one we're going to do is a bow tie. I told you we came up with some next gen questions. These are brand new questions, so I'm glad you all are joining. These are brand new questions. So no question bank has these. We've made these up. Myself, Nurse Brittany, our team has made these and put these together so we can teach you next gen that you haven't seen before. So we've got a nurse caring for a 68-year-old male admitted to the ICU 5 days ago for abdominal surgery, sudden fever, productive cough, purulent sputum, worsening O2 sats. What are we thinking is the diagnosis here? Well, before I look at my options, yeah, I'm probably thinking hospital-acquired pneumonia because they're in the ICU 5 days. We don't have ventilators. They're not aspirating. This is not your atypical. They're 68 years old, right? They're not in the community. They're in the hospital. So yeah, I would agree with you. Let's get a little bit more in depth to see what's going on here. Again, 68-year-old post-op 5 days. What do we worry about post-op, post-procedure? What is a mnemonic? We're worried about ASH. Which one of ASH is this individual post-op developing? Sepsis. It's happening right in front of us, right? You see that? I could ask this a total different way. I could have made this a prioritization question, 100%, right? And this is a patient I'm freaking out about. Complaining of increased shortness of breath, chills, yellow-green sputum, 102 fever, heart rate, tachycardic, tachypnic, blood pressure is okay, O2 sats, whoa. Kind of freaking out about that, 88%. Elevated WBCs, what type of white blood cell is elevated in this patient? Somebody tell me. You're looking at your labs, which white blood cell is elevated? Come on, my students that are in the course, y'all should know this. Good. It is, in fact, neutrophils. Good job. When you walk out and you're like, oh, their white blood cells are elevated. They have an infection. Okay, so what does that mean? I don't know. They've got an infection. What type of infection? Now, my students are going to be like, well, actually, the neutrophils are elevated, so I think it's a bacterial infection. Supportive measures? You should probably throw some antibiotics on that. And you're like, bam, that's a product of NCLEX High Yield. There you go. ABGs. Well, 7.35 to 7.45. Are we acidic, normal, or alkalotic? Acidic. We are, in fact, acidic. My O2 levels are low, and my PCO2 or my CO2 is elevated, which means I've got what type of acidosis? I've got respiratory acidosis. I'm not ventilating properly. So now I've got respiratory acidosis. So now we just went over ABGs. So much involved when we're studying. And I want you to see, and you know all of this. And now we've determined the cause, Pseudomonas. So what type of an antibiotic am I going to give them? Hospital-acquired pneumonia. We've got gram-negative. We could potentially develop staph, which is gram-positive. What are we going to give them? That's for anaerobic. Clindamycin's for anaerobic. That's for aspiration. We're going to give them broad spectrum antibiotics, right? Because we know we got gram-negative, but we also know in the hospital staph, which is gram-positive, is something that could be something that joins that Pseudomonas as well, too. So we're going to cover for all. All right, here's our bow tie. In the middle, it's straightforward diagnosis. What did we say? Hospital-acquired pneumonia, COPD, pulmonary embolism, aspiration pneumonia. It's a freebie question. So what are we worried about? We talked about this. This is 100% hospital-acquired pneumonia. We go to the left first because what are we going to do? Another freebie question. Are we going to elevate the head? Maybe. Initiate bronchodilator therapy? Yes or no? Does this have anything to do with bronchoconstriction? No, it's an infectious process, right? It's an infectious process. So is a bronchodilator going to do anything? No. We've got to treat the infection. So I get rid of that. I know that making them supine is going to make things worse. So making them semifowlers is going to be better. So position, yes. IV antibiotics as prescribed. Yes. And with hospital-acquired pneumonia, are we going to do nasopharyngeal suctioning? That'll probably make it worse. So yes, I would agree with you, 2 and 4. 2 and 4. We go all the way over to the right. Now, what are we going to monitor? Again, straightforward freebie questions. Are we worried about their white blood cell count? Yeah, I am. 16K. I want it to drop down below 11K, right? That will indicate to me that we are doing something about this infection. Are we worried about their 88% O2 sats? Absolutely. I've got 2 that I like, but we're still going to continue. Am I worried about their urine output at the moment? No. Am I worried about their blood glucose levels? No. So again, straightforward freebie question. Bow ties are not that complicated. And here in the near future, and there's Brittany, correct me if I'm wrong, we're going to be doing a group study with me that's going to be just on bow ties, and then another group study with me that's just on case studies, right? So we've got those coming up. We'll announce those dates here shortly, and you'll be working with me directly. So again, straightforward bow tie question. Cool. How many have done a group study with me? Especially the case study and bow tie ones. Those ones are a lot. They're a lot of fun. They're a lot of fun. All right, let's go on to a case study. With the case study, again, we're always looking to the left because we can add tabs. So always look to the left. In this situation, again, we're dealing with essentially the same person with a few differences. A 68-year-old ICU, 5 days, bowel resection surgery, cough, shortness of breath, fever. Again, same patient, but now we're turning it into a case study. A case study. So again, no known allergies, not a smoker. Hypertension, controlled diabetes, cool. Shortness of breath, green sputum, fevers, chills, fatigue. Same thing, 110 heart rate, 28, 88%. Same patient, again, 16K. ABGs show the same thing. Same exact patient, but now we're turning it into a case study. So which 3 findings? Notice I gave you how many you're looking for. So now it's your choice, it's your duty to choose 3 of these. Am I freaking out about respiratory rate of 28 breaths per minute? Yes, because which one of immediate ask graph am I worried about with that respiratory rate? 100% airway. Blood pressure, am I concerned? Why is this marked as... Brittany, the answers are here. I'm going through this like there's no answers. There, we'll explain it. There's Brittany, did you catch that?
Yes.
We just gave away the answers. Nonetheless, okay, so we know it. I'm sitting here doing it like the answers aren't right in front of you. We're going to explain each one step by step. Blood pressure, obviously, we're not worried about it. Oxygen, yes, it is airway. Productive cough, okay, I may have held on to that, maybe. White blood cell is something I may have thought about, but now I'm down to white blood cell and temperature. Why is temperature one of the three that I'm going to choose? These ones for sure are airway, airway. But does white blood cell count of 16,000 necessarily mean infection, especially after bowel resection? No, because white blood cell count can be elevated due to stress. Yeah. So it's not indicative of infection. It could mean stress from the surgery. So you see why I chose temperature, which is now sepsis of ask graph. So I put this in here for a reason. Do you see why I threw 16,000 in there? You know how many people are going to be sitting there thinking 16,000, 60,000, that's high. That's high. I should probably choose that one. Or people that don't know what a normal respiratory rate is. They're like 28. I know it's like 20 something. 20 something. Is it 28? That sounds about right. Okay, I'll choose the white blood cell. You see why I put this in there? I put it in on purpose. Because I want you to see that elevated white blood cell count doesn't mean infection. Right? In this situation, it does, but it doesn't always mean that because this patient also had surgery. So you see why that's so important. We don't do ABCs here. We do ask graph. ABCs, we don't do that. We are only ask graph in here, right? We are team ask graph. All right. Matrix or grid. Matrix or grid. It's all good. I'm just teasing. I'm just teasing. All right. Again, matrix or grid. Just because this patient has hospital-acquired pneumonia, do you think that I need to know just hospital-acquired pneumonia, or do I need to know the differentials? Aspiration, atypical. Community-acquired. Right? We can't do ventilator, but I could throw ventilator in here just as well and just see if we know the signs and symptoms. Right? I can compare all of them. I can compare all of them. So again, how do I approach matrix or grid style questions? Do I do column by column or do I do row by row? I always do column by column. And the reason why we do column by column is because it keeps me organized. I know hospital-acquired pneumonia. I don't need to go hospital to aspiration to atypical. I don't want to do that. It's going to confuse me. It's like driving on a highway. That's my analogy. And I'm going from the left lane to the middle lane to the right lane, back to the left lane to the middle lane to the right lane. No, I'm going to stay in one lane because I know the speed limit. I know where the other cars are. I know I'm in my zone. I'm in my lane and I'm focused. So hospital-acquired pneumonia. Do I develop productive cough and purulent sputum? Yes, I do. With hospital-acquired pneumonia, do I have impaired swallowing? No, I don't. Is hospital-acquired pneumonia found with mycoplasma pneumonia? No. Will I see new infiltrates on chest x-ray when I do a chest x-ray, which I'm going to order on all these patients? Yes. Positive sputum cultures for Pseudomonas. What's the number one cause for hospital-acquired pneumonia? Pseudomonas followed by what? Staph, which gives me gram-positive, gram-negative, which means what type of antibiotics? Beat it in your head. Broad spectrum. Cool. Aspiration pneumonia, productive cough with sputum, purulent sputum, purulent sputum. With purulent sputum, no. Not purulent sputum. Productive cough, I would take. Purulent sputum, no. But typically, you have to also understand, with aspiration, we've got some sort of impaired swallowing. Is our cough and our gag reflex maybe not necessarily fully there? Potentially. So we have to be careful with that, right? Impaired swallowing. Yeah, absolutely. Absolutely. Neurological disorders, strokes, alcohol, respiratory depression, benzos, opioids, intoxication, right? New infiltrates on chest x-ray. Oops. Yeah. Or sorry, does this have to do with mycoplasma? Is this found with mycoplasma? No. New infiltrates. Yes. Yes, yes, yes. And is aspiration dealing with Pseudomonas, or is this an anaerobic infection? It's anaerobic. So your bacteroids, things that are in your body. And the last one is atypical pneumonia. With atypical pneumonia, do I have a productive cough with purulent sputum? No, I do not. Do I have a productive cough? Yes. Purulent sputum? No. Impaired swallowing? No. Infiltrates on chest x-ray, or sorry, mycoplasma. I always skip mycoplasma for some reason. Yeah. Yeah, absolutely. New infiltrates on chest x-ray. Mycoplasma does not show new infiltrates on pneumonia. I mean, on chest x-ray. It does not show infiltrates on chest x-ray. So it's a walking pneumonia, atypical pneumonia. So it doesn't present like regular pneumonia. So in this one, but let's just say majority of people did choose this, okay? And I'm going to show you why this doesn't make a difference. And don't beat yourself up if you do choose it. And then positive sputum cultures for Pseudomonas? Well, clearly not, because the issue here is mycoplasma. How many questions do I have here? 5, 10, 15. Out of 15, I missed one. Fair? Let's just say we all chose it. I chose it with you. I chose new infiltrates because, well, pneumonia, I thought it might have on chest x-ray. I didn't know atypical doesn't show infiltrates, but I think it does. I got 14 out of 15 right. Somebody do the math for me. What is my percentage on this question alone? What's 14 out of 15 equal? Somebody do the math for me. 15, 93? 93%. Okay. 93%. Well, this is all content. Can we agree upon that? This is straight content, right? But not only content, I taught you test-taking strategies. This is just a select all that apply. That's all that is. And I've taught you the 5 types of questions on the boards. This is just that. If I'm scoring 93%, even if I miss the one, why do I say focus on each question individually and watch you pass? Students are passing 85 and out, 96 and out. I don't even care if it's 150 and out, 150 and out and a pass. We're taking it. We're taking it, right? So again, very, very straightforward. Let's do one more part of this. We might be able to do 2. All right, drop down. What type of question is a drop down? Of the 5 types of questions, select all, apply? No. Prioritization? No. Further teaching, further intervention? No. So it's a freebie question. Straightforward. What are they going to develop? What can they develop? Sepsis, pulmonary embolism, or chronic bronchitis? Sepsis, right? Ask graph. We're worried about them turning into sepsis. But why are they at risk for sepsis? Is it their pain? Is it that Pseudomonas? Or is it their blood pressure? Clearly, it is the Pseudomonas that's causing it. Straightforward freebie question. Straightforward freebie question. All right, let's squeeze in one more. Intervention that we're going to do with this patient. With intervention, what type of a question is this? It's a select all that apply. Is it risk factors? No. Is it signs or symptoms? No. Is it education? Yes. Intervention, education, same thing. It's a type of select all that apply question. So now, are we going to give in hospital-acquired pneumonia in this patient? Are we going to start them on IV antibiotics? And if so, what type? Broad spectrum. Yes. Bronchodilator. No. Why? It's not a constriction issue. It's an infectious process. Elevating the head of the bed. Position. Yes. Is this GERD that's causing it, or an antacid or reflux? Is an antacid going to do anything here? No, it's not. And then are we going to obtain a sputum culture? Yes, because what do we say? It could be Pseudomonas, it could be staph, it could be other infectious processes with hospital-acquired pneumonia. If a patient develops pneumonia, what are we going to do? Somebody tell me. NPO, IV fluids, pain as needed if they have that pleuritic chest pain. PPI, probably not unless we're really making NPO for a long time. Antibiotics and antiemetics as needed. Do you see how NIPA still works in respiratory? These things that I've come up with to help you all pass, you should not take them lightly. You should be knowing these. They should be on your whiteboard. They should be on your whiteboard. Why no antacid? This is not caused by GERD, nor is it caused by acid reflux. It is in fact caused by an infection. So you need IV antibiotics. Cool. All right. How do we feel about today's lecture? Good, good, good. All right, perfect. Well, couple of things. Again, we got trivia right after this. So stay on, log on. Remember, top 3 get prizes, or top 3 or 5? There's Brittany?
5.
Top 5 get prizes. Top 5 get prizes. So make sure with the holidays, be patient because some of these things are not getting shipped out or production is a little backed up. Thank you for the compliment. I really appreciate that. What's it called? So just remember, production is a little bit behind because of the holidays. Shipping is a little bit behind because of the holidays. So just be patient. You will get it. So with that said, if I did anything to offend anybody, I apologize. If I can get better, please let me know. If you want to speak to me about your CPR report, or you want to speak to me directly about any of the courses, on-demand live courses coming up, please feel free to reach out to me. And we will make sure that we get a call between myself, Nurse Brittany, and our staff. We will make sure we call you back. So with that said, Nurse Brittany, how long do you need to set up trivia?
I usually start at around 7:10 Eastern.
Okay, cool. So 7 minutes from now, we will start trivia, and I will let Nurse Brittany become host. And with that said, everyone, thank you all so much for joining. If you can please, please, please spread the word. Please spread the word any and everywhere. We would love to get back up to that 500. We would love it. Oh, thank you for the belated birthday wishes. My birthday was what? Yesterday? Day before? Monday. So yeah, I turned 21 again. 21 again. I'm 21 forever. Ask me how old I am, how old I'm turning, how old I was, how old I'm going to be. It's always going to be 21. Okay. So with that said, I appreciate you all so much, so much. Thank you all for joining and supporting us so much. And please, please, please spread the word. We'd love to get back up to that 500. I know the holidays are coming up, which reminds me, keep an eye out for when we're going to be doing the next Zoom. Next Zoom is not going to be next Wednesday because that is in fact a holiday. And then the next one is going to be after New Year's, which is going to be on the
January 2nd.
January 2nd is going to, so it's going to be on a Thursday, on a Thursday. So we'll announce it. Make sure you got our emails. Make sure you sign up for all our social media and everything like that. With that said, everyone, good luck with trivia. I'll see y'all later. Take care.
Bye, Dr. Z. We will be getting started in about 1 minute. Okay, so let's go over this one. Sorry, guys, it takes me a minute to unmute myself because the bar kind of disappears. Okay, so what key points should the nurse include when educating a patient about statin therapy? This is a select all that apply. So option D, take statins in the evening. Yeah, statins are going to be most effective when you take them at night, because cholesterol synthesis peaks while you sleep. So I would go with that one. Have liver enzymes monitored regularly? Yes, statins can affect liver function, so monitoring is going to be essential for sure. Avoid taking statins with food. No, statins can be taken with or without food, so this wouldn't be good to educate someone with. So I wouldn't go with that. And then A, report any muscle pain or weakness. Yes, muscle pain can indicate what? Does anyone know? Muscle pain can indicate what? Yes, rhabdomyolysis. Nice job, everyone. Yup, exactly. It's a rare side effect, but it is serious if it does happen. Okay, so let's go over this one together. So a postpartum patient reports a sudden severe headache and blurred vision. The nurse suspects. So endometritis. No. Endometritis would cause fever, uterine tenderness, not neuro symptoms. So I wouldn't go with that. Deep vein thrombosis. So DVT usually presents with that localized leg swelling and pain, not a headache, right? So I wouldn't go with that. And most of you didn't. Preeclampsia, yes, severe headache, blurred vision. Those are key symptoms of preeclampsia. Yeah, and they can occur postpartum, very important to watch for. And then postpartum hemorrhage. Hemorrhage presents if there's heavy bleeding, tachycardia, not headache, not vision changes. No, guys, preeclampsia is not only during pregnancy. It's a big thing after pregnancy that a lot of women can develop. So you're supposed to monitor for if you see any symptoms like you start having blurry vision or a headache. So definitely know that it's not just during pregnancy, it's in that postpartum period too that you want to watch for that. Okay, so let's go over this one together. So, which patient is at highest risk for a pulmonary embolism? Let's see our options. D, a patient with a history of asthma. Why don't we go with this one? Why don't we go with this one? Why don't we like this answer? Anyone? Am I not seeing? No, no one wrote anything. Why are we not going with D? Yeah, I would say unrelated. I wouldn't go with that. What about C, a post-op patient who underwent hip replacement surgery? Why do we think this person has the highest risk for PE? Yeah, VAP, right? Exactly. What about a patient with chronic bronchitis? Yeah, not related at all. What about a post-op patient on bed rest? Why C over A? Because the question says the highest risk. So yes, A would be correct, but it says the highest risk, which is why when I would narrow it down to A and C, I'd get rid of A and go with C. Does that make sense to everyone? You are very welcome. Okay, so let's go through this one. The nurse observes a patient with Parkinson's disease having difficulty swallowing. What is the priority action? So monitor weight daily. Why don't we go with this one? Why don't we go with Oh, I'm sorry, I accidentally muted myself while I was speaking. So why don't we go with monitor weight daily? Yeah, I would say it's not it doesn't concern weight, right? It's unrelated. So I wouldn't go with that. Offer thickened liquids. Why don't we go with that one? Why are we not going with option C? Why don't we go with option C? That won't help. What about encourage small frequent meals? It says, what is the priority action, right? So why would we go with consult a speech therapist? Because they're going to do a swallow evaluation, right? And determine safe dietary modifications for this patient's maybe thickened liquids or specific strategies. So referral to a speech therapist early is going to be pretty important because we want to prevent aspiration pneumonia. Yeah, exactly. Okay, let's go over this one. So select all that apply. Which of the following are symptoms of anaphylaxis? Okay, so bradycardia. Why did 40 of you decide to go with bradycardia? Can everyone hear me? Can everyone hear me? I don't know why. Is everything frozen for me? Can everyone? Oh, yes. Okay, awesome. So why did you guys decide to go with bradycardia? It looks like a lot of you did. It would not cause bradycardia, tachycardia. Anaphylaxis usually causes tachycardia from that low blood pressure. So I wouldn't go with bradycardia. What about hypotension? Yeah, vasodilation caused by histamine leads to hypotension, definitely. Wheezing, yeah. So airway narrowing occurs due to bronchospasm, which is a hallmark of anaphylaxis. And then angioedema, yes, I would go with that as well, definitely. Does that make sense? Everyone got that? Awesome. Okay, let's look through this one. Deep partial thickness burns on the legs will likely appear. So blackened and charred. This describes what? What does this describe? What type of burn? Full thickness, exactly, RA, Noreen. Yup, full thickness. So I wouldn't go with this. Pale and waxy, what does that describe? And this is superficial partial thickness. This is superficial partial thickness. And that could blanch if you put pressure, but these are less severe. B, red, moist, and blistered. Yeah, so deep partial thickness burns involve the dermis and the epidermis, which leads to a red, moist appearance with those fluid-filled blisters. A, dry and leathery. What does this describe? Full thickness burns. And that would destroy the epidermis and the dermis, and that's where you get that leathery appearance. Let's go over this one. So a nurse assesses a patient with pericarditis. Which finding is most concerning? Friction rub on auscultation. Why don't we go with this one? Because this is expected, so I'm not freaking out about this. Low-grade fever, that's also common, not freaking out about that. Chest pain relieved by sitting up. That's a classic sign in pericarditis. We're not freaking out about that. Distant heart sounds, that can tell us what? Cardiac tamponade, exactly. That's life-threatening. That's a complication of pericarditis. We're freaking out about that. Awesome job. Nice job, guys. Okay, let's see. A patient receiving nitroglycerin reports a headache. The nurse should lower the dose by half. Changing the dose is going to require a doctor's order. So I'm not going with that. We can't just lower the dose. We can't prescribe. Notify the healthcare provider. We can manage a headache. We don't have to call the doctor. So the doctor would yell at us if we called them for that. Stop the nitroglycerin infusion. A headache is a mild side effect. We're not stopping the medication for that. Administer acetaminophen. Yes. So headaches are common. It's a common side effect of nitroglycerin because of the vasodilation. So acetaminophen will treat that headache safely. Okay, so a patient with a total hip arthroplasty should avoid which position? Lying on the non-operative side. This is generally safe, so I wouldn't freak out about this. Flexing the hip beyond 90 degrees. Yes, I would avoid this position because flexing the hip more than 90 degrees can dislocate the hip prosthesis, so I wouldn't go with that. Sitting at a 90-degree angle, that can definitely be risky. I'd narrow it down between B and C, but more so C. Yeah, more so C, but definitely B could be risky, but beyond 90 degrees, I'm freaking out about that. Supine with legs apart. This position keeps the hip in alignment. That's going to prevent dislocation, so I wouldn't go with that. This is a little tricky. This is a little, those two answers together kind of threw it off a little bit because they're both not great, but definitely C. Okay, so let's see this one. For a COPD patient, which intervention is most appropriate? Administer antitussive medications. No. Those would not be recommended. Why? because coughing helps to clear the secretions, right? So I wouldn't go with that. Restrict fluids. Fluids shouldn't be restricted because that's going to help actually thin the mucus secretions. Exactly. Provide low flow oxygen therapy. Yeah, COPD patients rely on that low flow oxygen to avoid suppressing their hypoxic drive to breathe. So I would go with B. Encourage deep, rapid breaths. No, that can increase the risk of air trapping and exacerbate that patient's symptoms. So I wouldn't go with A. Sorry, it takes me a second to unmute myself. So, which food is appropriate? A patient with ulcerative colitis is prescribed a low residue diet. Which food is appropriate? Okay, so let's go through all the answers here. Nuts. Why don't we go with nuts? Why no? Why can't I see the chat? Why no nuts? Where'd my chat go? Hold on one second. My chat just disappeared. Oh, hold on one second. I can't find the chat. Okay, here we go. Yeah, they're gonna worsen those symptoms during the flares. Nuts are high fiber content, right? Exactly, Star Nurse. Yeah, exactly. Yeah, so I wouldn't go with that. Also, they're hard to digest. So they can remain undigested and that can just trigger or worsen things. So yeah, I wouldn't go with that. What about popcorn? What about popcorn? I see a lot of people, well, a chunk of people, 15 people went with that. Yeah, they're high in soluble fiber. They're also again hard to digest. They're hard to break down. So they could definitely just their rough texture, they could trigger that gas, bloating, that urgency. So I wouldn't go with that. What about raw vegetables? Raw vegetables. Again, with the fiber, yep, exactly. They're hard to digest. They could irritate, worsen everything, bloating, cramping, diarrhea, not going to be good. Why do we like white bread? Why do we like white bread? Low in fiber, and it's easy to digest. Yeah. Exactly, hyperkalemia. So spironolactone is a potassium sparing diuretic, right? And it blocks aldosterone. which then causes the kidneys to retain potassium while excreting sodium and water, which can lead to that high potassium level hyperkalemia. So yes. Awesome job, everyone. Let's see our winners. Okay, third place, second place, Juliet, and first place. Awesome, awesome, awesome. Nice job. And then let's see fourth and fifth. Perfect. Our runners up. Awesome. So all 5 of you guys, please email contact@nclexhighyield.com. Show them, oh, I never saw this before. This is cool. Show them a photo of proof that you won. And you will receive your prize. I believe first and second gets the nurse boxes. Third, fourth, and fifth get t-shirts. And keep in mind, guys, if you have won previously, even if you haven't claimed the prize and you won, you still are considered that you won, so you can't win again. You can only win trivia night once, okay? Just a heads up. All right, I hope everyone enjoyed. You guys all did an awesome job. I hope you had some fun. You're so, so welcome, and I will see you guys next week. All right, bye, guys. Bye, everyone.